Good morning, everyone. I'm Dr. Alaa Mosbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University. Today, I wanted to discuss with you obesity and pregnancy. So, what we wanted to discuss today? Definition and the prevalence of overweight and obesity, classification of body mass index, grades of recommendation, pre-pregnancy care, antenatal care, planning labor, postnatal care, management of pregnancy following bariatric surgery, and of course today we wanted to discuss about the guidelines by RCOG Green Top Guideline November 2018. Also some information from WHO in 2017. Let's go. About the definition and the prevalence, obesity is a condition in which excess body fat has accumulated to such an extent that health may be adversely affected. In 2016, 39 of women aged 18 and over were overweight. This is according to WHO. Also, in 2016, again, the prevalence of obesity. In 2016, the prevalence of obesity is 36 in USA and 32 in Egypt for people aged 18 and over, also according to WHO. Let us go to see this map. The deep green one with the highest incidence or prevalence. As you see here, in USA is the highest, also here in Egypt, okay, and some Asian countries and African countries also. So what about classification according to body mass index? We can divide them into underweight if body mass index less than 18.5, normal range if body mass index 18.5 to 24.99, overweight if body mass index more than or equal to 25, pre-obese from 25 to 29.99, obese class 1 from 30 to 34.99, obese class 2 from 35 to 39.99, obese class 3 above 40 or equal to 40. This is according to the body mass index, which can be calculated by weight in kilogram divided by square meter. Okay, we wanted to know grades of recommendation because our lecture today depends on the guidelines and the grades for each item. So to understand it, please look to this table. On the left side, this is classification of evidence levels from 1 to 4. And the top one is a strong one, like this first one, high quality meta-analysis, systematic review of randomized controlled trials or randomized controlled trial with a very low risk of bias. With lowering down, the evidence is lower. Till the end here, the lowest evidence. On the right side, this is grades of recommendation. A, B, C, D. A is the strongest evidence. At least one meta-analysis or systematic review or randomized controlled trial. So, the strong evidence is grade A recommendation, the strongest one. B is lower, C is lower, D is lowermost. What about this one? This one is expert opinion or good practice point depending on clinical experience. So it is not depending on studies as these grades, but depend on clinical experience or expert opinion. Okay, so take this sign. When you see this sign, this only depending on clinical experience. Okay, let us go. About pre-pregnancy care, women of a childbearing age should have the opportunity to optimize their weight before pregnancy. Weight and body mass index should be measured. Advice on weight and lifestyle should be given during preconception counseling or contraceptive consultation. And this is grade of recommendation of expert opinion, depending on clinical experience, as we said before. Women of childbearing age with body mass index 30 or greater should receive information and advice about the risks of obesity during pregnancy and childbirth. Of course, it's very important. And be supported to lose weight before conception and between pregnancies to avoid the hazards of obesity during pregnancy and labor. Grade recommendation D. Women should be informed that weight loss between pregnancies reduces the risk of stillbirth, hypertensive complications, and fetal macrosomia. Weight loss increases the chances of successful vaginal birth after cesarean section. Grade B recommendation. Women with body mass index 30 or greater wishing to become pregnant should be advised to take 5 mg folic acid supplementation daily, starting at least 1 month before conception and continuing during the first trimester of pregnancy. And we know that folic acid as a prophylaxis or prevention from neural tube defect. Grade D recommendation. Obese women are at high risk of vitamin D deficiency. However, the evidence on whether routine vitamin D should be given to improve maternal and offspring outcomes remains uncertain. Grade B recommendation. What about the antenatal care? All pregnant women should have their weight and height measured using appropriate equipment and their body mass index calculated at the antenatal booking visit. Measurements should be recorded in the handled notes and the electronic patient information system. Grade D recommendation. For women with obesity in pregnancy, consideration should be given to re-weighting women during the third trimester to allow appropriate plans to be made for equipment and the personnel required during labor and birth. Of course, very important in third trimester. Grade of recommendation depending on clinical experience. There is lack of consensus on optimal gestational weight gain until further evidence is available. A focus on healthy diet may be more applicable than prescribed weight gain targets. Good points of practice. All pregnant women with booking body mass index 30 or greater should be provided with accurate and accessible information about the risks associated with obesity and pregnancy and how they may be minimized. Women should be given the opportunity to discuss this information. This grade D recommendation. Again, in antenatal care, dietetic advice by trained professionals should be provided early in the pregnancy where possible. Good point of practice. Anti-obesity or weight loss drugs could be used or not. It is not recommended for use in pregnancy. Grade C recommendation. What about risk assessment during pregnancy? Pregnant women with booking body mass index 40 or greater should be referred to an obstetric anesthetist for consideration of antenatal assessment. Grade D recommendation. Difficulties with venous access and regional and general anesthesia should be assessed because it is very important. An anesthetic management plan for labor and the birth should be discussed and documented. Grade D recommendation. Women with a booking body mass index 40 or greater should have a documented risk assessment in the third trimester of pregnancy. Grade D recommendation. What about screening, diagnosis, and the management of gestational diabetes in obese patients? All pregnant women with booking body mass index 30 or greater should be screened for gestational diabetes. Of course, they are a high risk for diabetes. Grade B recommendation. Screening and diagnosis and the management of hypertensive complications. An appropriate size of cuff should be used for blood pressure measurements taken at the booking visit and all subsequent antenatal consultations. Grade C recommendation. Clinicians should be aware that women with class 2 obesity and greater have an increased risk of preeclampsia compared with those with a normal body mass index. Grade B recommendation. Screening, diagnosis, and the management of hypertensive complication. Women with more than one moderate risk factor, body mass index 35 or greater, or first pregnancy, or maternal age of more than 40 years, or family history of preeclampsia or multiple pregnancy may benefit from taking 150 milligram aspirin daily from 12 weeks of gestation until birth of the baby. Grade B recommendation. So it's something very important to give aspirin 150 milligram from 12 weeks upward during pregnancy. For whom? For those with more than one moderate risk factor, as mentioned. Prevention, screening, diagnosis, and the management of venous thromboembolism in obese patients. Clinicians should be aware that women with body mass index 30 or greater pre-pregnancy or at booking have pre-existing risk factor for developing venous thromboembolism. So, yes, body mass index 30 or more is a risk factor for venous thromboembolism. Grade B recommendation. Risk assessment should be individualized, discussed, should be individually discussed, assessed and documented at the first antenatal visit, during pregnancy, intrapartum, and postpartum. Yes. Grade D recommendation. Screening, diagnosis, and management of mental health problems. Is obesity a risk factor for mental health problem? Women with body mass index 30 or greater are at increased risk of mental health problems and should therefore be screened for this in pregnancy. Grade D recommendation. There is insufficient evidence to recommend specific lifestyle intervention to prevent depression and anxiety in obese pregnant women. Good point of practice. Screening for chromosomal anomalies during pregnancy. All women should be offered antenatal screening for chromosomal anomalies. Grade B recommendation. Consider the use of transvaginal ultrasound in women in whom it is difficult to obtain nuchal translucency measurements transabdominally. Good point practice. Screening for structural anomalies during pregnancy. Screening and diagnostic tests for structural anomalies, despite their limitations in obese population, should be offered. However, women should be counseled that all forms of screening for structural anomalies are more limited in obese pregnant women. Grade C recommendation. How and when should the fetus be monitored antenatally? Serial measurement of symphysis fundal height is recommended at each antenatal appointment from 24 weeks gestation, as this improves the prediction of a small for gestational age fetus, and of course also for large for gestational age. Grade B recommendation. Women with body mass index greater than 35 are more likely to have an inaccurate symphysis fundal height measurements and should be referred for serial assessment of fetal size using ultrasound. Good practice point. How and when should the fetus be monitored antenatally? Where external palpation is technically difficult or impossible to assess fetal presentation, ultrasound can be considered as an alternative or complementary method. Good practice point. What about planning for labor? Women who are multiparous and otherwise low risk can be offered the choice of sitting for planning their birth in midwifery-led unit with clear referral pathways for early recourse to consultant-led units if complication arise. So long as she is low risk and the multiparous, yes, you can depend on midwifery-led unit, but at the same moment, at any time, you can shift to consultant-led unit. Grade C recommendation. Active management of third stage should be recommended to reduce risk of postpartum hemorrhage. Grade A recommendation. The strongest recommendation, of course, grade A. Again, elective induction of labor at term in obese women may reduce the chance of cesarean birth without increasing the risk of adverse outcomes. The option of induction should be discussed with each woman on an individual basis. Grade B recommendation. The decision for a woman with maternal obesity to give birth by planned cesarean section should involve multidisciplinary approach, taking into consideration the individual woman's comorbidities, antenatal complications, and wishes. Grade C recommendation. Where macrosomia is suspected, and this is of course can happen with obese patients, induction of labor may be considered. Parents should have a discussion about the options of induction of labor and the expectant management. Grade B recommendation. Women with a booking body mass index 30 or greater should have individualized decision for vaginal birth after cesarean section following informed discussion and the consideration of all relevant clinical factors. Good practice point. Class 1 and 2 maternal obesity is not a reason in itself for advising birth within CLU consultant-led unit, but indicates that further consideration of birth setting may be required. Grade D recommendation. The additional intrapartum risks of maternal obesity and the additional care that can be provided in consultant-led unit should be discussed with the woman so that she can make an informed choice about planned place of birth. Good practice point. Women with body mass index 40 or greater should have a venous access established early in labor, and the consideration should be given to the setting of a second cannula. Yes, insert two wide bore cannula is very important. Grade of recommendation depend on clinical experience. Good practice point. Although active management of third stage of labor is advised for all women, the increased risk of postpartum hemorrhage in those with body mass index greater than 30 makes this even more important. Grade B recommendation. Women with class 1 obesity or greater having a cesarean section are at increased risk of wound infection and should receive prophylactic antibiotic at the time of surgery. Grade A recommendation. And this in picture, you can see the wound infection of the cesarean section. Women undergoing cesarean section who have more than 2 centimeters subcutaneous fat should have suturing of the subcutaneous tissue space. So clothe this space, don't leave it if it is more than 2 centimeters, in order to reduce risk of wound infection and wound separation. Grade A recommendation. There is lack of good quality evidence to recommend the routine use of negative pressure dressing therapy and the insertion of subcutaneous drains to reduce the risk of wound infection in obese women requiring cesarean section. So there is no good evidence about subcutaneous drain in obese patients. Grade B recommendation. What about postnatal care? Obesity is associated with low breastfeeding initiation and maintenance rates. Women with a booking body mass index 30 or greater should receive appropriate specialist advice and support antenatally and postnatally regarding the benefits, initiation, and the maintenance of breastfeeding. So we should encourage breastfeeding. Good practice point. Maternal obesity should be considered when making the decision regarding the most appropriate form of postnatal contraception. Good practice point. Women who have been diagnosed with gestational diabetes should have postnatal follow-up. Grade D recommendation. Women should be supported to lose weight postpartum and offered referral to weight management services where these are available. Good practice point. What about management of pregnancy following bariatric surgery? We know that nowadays there is bariatric surgery, many types of bariatric surgery as you see in this picture, like adjustable gastric band, like laparoscopic sleeve gastrectomy, like laparoscopic gastric bypass. So, a minimum waiting period of 12 to 18 months after bariatric surgery is recommended before attempting pregnancy to allow stabilization of the body weight and to allow the correct identification and the treatment of any possible nutritional deficiencies that may not be evident during the first months. So it's very important to tell the lady, please wait for 12 up to 18 months after the surgery to be pregnant. Grade D recommendation. Women with previous bariatric surgery have high risk pregnancies and should have consultant-led antenatal care. Good practice point. Again, women with previous bariatric surgery should have nutritional surveillance and screening for deficiencies during pregnancy. Grade D recommendation. Women with previous bariatric surgery should be referred to the dietitian for advice with regard to their specialized nutritional needs. Grade D recommendation. This is my last slide. I hope this lecture was clear and these guidelines was informative for you. Thank you. Dr. Alaa Mosbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University.